Hi, this is Brian Kim, and I'd like to share with you this technique that I developed to hold the eye straight without using a cotton tip, forceps, or a fixation ring to do capsulorhexis. Sometimes patients, out of anxiety or if they have a very strong Bell's reflex, will turn the eye upward or they can't keep it straight. For a right-handed surgeon like me, the right eyes are less difficult to keep the eye straight. In other words, the right eye is going to bell upward, and I can use a cannula to hold the eye downward, and this is fairly straightforward. However, for a left eye that tries to bell upward, it is going to be more difficult to use that cannula to hold the eye straight. You have to try to pull the eye down somehow. And using a cannula to pull the eye downward is a little bit more of a challenge because there's no grasping element to the cannula. So you can see this is a right eye of a patient and the patient's belling upward. I'm using a cotton tip to try to hold the eye steady during my marking for my capsulorhexis. The eye is turning towards the left, which is the upward position, and I'm having to use this cotton tip to really apply quite a bit of force to keep the eye downward, which is to the right. I'm pushing some lidocaine into the eye and then some dispersive viscoelastic. I'm going to use the cannula to hold the eye straight as I make my triplanar corneal incision. I make a vertical groove and then tunnel and then enter into the anterior chamber. And because this eye is trying to turn upward, which is to the left, I'm able to use a cannula to hold it essentially against the patient's brow, and that cannula is able to limit movement upward and to the left. And so by keeping the cannula nice and still, it doesn't require a whole lot of force. I'm just holding it in place, and this helps to keep the eye straight and prevents it from moving upward. I'm able to do my puncture-style capsulorhexis. I puncture with the rhexis forceps and then pull downward and then sweep a little bit to the right to create a little bit of a C shape. I grab the edge of the rhexis and then begin to start to move the rhexis in a counterclockwise manner, pulling and re-grabbing successively. You can see how steady the cannula is, and as a result is able to hold the eye very steady. I have very good control of the eye during the rhexis. It's not moving whatsoever during this maneuver. So that was quite successful, using the cannula to hold the eye steady in this right eye. This is another right eye, and you can see I'm going to try to make my corneal mark, but this patient is resistant to my movement. And that's usually the clue. When I use the cotton tip to manipulate the eye, I can feel the patient resisting me as I do it. And so I try to help them relax. I tell them, try not to resist me, try to make your eye as loose as possible. And this patient was able to allow me to make my corneal mark and make my paracenteses incisions. And then I'm injecting intracameral lidocaine and then viscoelastic. So then I do my triplanar corneal incision. I make a vertical groove and then tunnel and then enter the anterior chamber. So here I notice that the patient's still looking upward, and I'm going in with my capsulorhexis forceps. And as I try to straighten out the eye using the rhexis forceps, I notice that the eye is very resistant. You can see I'm kind of pushing it side to side, and I'm telling the patient, try to loosen your eye. I'm trying to do your surgery. Keep it loose. Keep it as loose as possible, and I can still see I'm not really getting anywhere. So I'm using the cannula to hold the eye still, keeping it straight, and I'm using it almost as a pivot point, as a fulcrum. And so I make my puncture style capsulorhexis. I'm puncturing, pulling down, and then I'm grabbing the flap. You can see that there is significant resistance from the patient because where the cannula is, you'll see some corneal stria. And so as I'm making my capsulorhexis, I'm grabbing and re-grabbing. I'm trying to be as slow and methodical as possible. I'm grabbing and re-grabbing, going around. You can see the eye is nice and still. However, as I'm getting to this last part of the rhexis, you can see significant stria in the cornea. Thankfully, I'm able to finish the rhexis without much trouble, but when I take the instruments out, look how much force the patient's exerting. The eye pops right back up. This goes to show how this cannula technique is able to keep the eye nice and straight. I didn't have to use any forceps or a ring, which can cause discomfort to the patient. And sometimes as the patient resists you, you can actually cause some tears in the conjunctival tissue as well. So how would you deal with a left eye? In this case, the eye is going to pop up, which is towards the right of the screen. And how would a cannula hold an eye and pull it downward since the cannula is in a paracentesis incision on the left side? I'm using a cotton tip to hold the eye, and making my paracentesis incisions first on the right side and then on the left side. I'm injecting intracameral lidocaine and then dispersive viscoelastic. I try to make my triplanar corneal incision, but how am I going to pull the eye downward when this patient's belling upward? Well, this is what you have to do. You have to take advantage of the Orlock phenomenon. Normally, when we learn about cataract surgery, Orlocking usually refers to something that we don't want to happen during surgery. And that's when we're using instruments and we're trying to slide the instruments into the eye, but we get resistance when we torque the instrument against the incision, and this causes friction and a locking or Orlocking of the instrument to the wound, and this limits our ability to do the cataract surgery. Well, we can take advantage of this phenomenon by turning the cannula and twisting it in such a way that it creates friction at the level of the incision. You can take advantage of this phenomenon and then pull the eye downward. So in this left eye, otherwise it would be very difficult to pull that eye downward short of using forceps, but you can use this Orlocking phenomenon, twisting the cannula, and you're able to pull the eye downward, as you can see as this case progresses. I make my triplanar corneal incision, I make a vertical groove, and then tunnel, and then enter the anterior chamber. And then by holding the cannula still in the same fashion, I start my capsulorhexis. I make my puncture style capsulorhexis, puncturing and then pulling downward, and then swooping a little bit to the right, creating a little bit of a C-shaped configuration. I grasp the edge of the rhexis flap. You can see the cannula is essentially parallel to the limbus in that area in order to create that leverage to keep that eye down. I can feel the patients resisting me, trying to pull the eye upward, but I'm actively using the cannula to pull the eye downward. And as I'm doing this, I'm also doing my capsulorhexis. Again, I'm using the corneal mark to size and center my rhexis, and I'm following the marks, and I'm able to get a very well-centered and very well-controlled capsulorhexis using this technique. So this technique is really applicable for those patients who can't keep their eyes still or they have a strong Bell's reflex. Rather than using forceps or a ring, the patient can suddenly move and cause a corneal abrasion or a conjunctival laceration and subconjunctival hemorrhage, and this can really undermine your surgery. This is an atraumatic way to control the eye during capsulorhexis. Again, for the right eyes, if the eye bells upward, you can use a cannula just to hold the eye steady against the brow, and this will keep the eye nice and straight. However, for the left eyes, this is more involved. You have to take advantage of the Orlocking phenomenon, and you can twist the cannula, make it parallel to the limbus in that area of the incision, and pull the eye down and make it nice and straight. You can see that there's very good control for capsulorhexis by doing this maneuver. So I hope these pearls are helpful to you, and I thank you for your attention.